esteemed faculty, senior residents and others. So today will be Morbidity Clinic. For this we have decided to present about snake bites. So my talk is titled Snakebite Management, Perils and Pitfalls. So this is the broad outline of what we'll be going through today. First, we'll be looking at a little bit of background about how big snakebite is a problem, and especially what are the specific problems which we face in our area, especially in southwestern Rajasthan. Then I will be presenting a case of snakebite who underwent multiple morbidities, who had multiple morbidities. So that will let us take a peek into what are the unique challenges which we are facing in management of snakebite patients. And we will also be looking at the summary of outcomes in our institute over the past 1.5 to 2 years. And then we will have some discussion on the solutions and what we can do to move forward to reduce this morbidity and mortality. So coming on to the background, if we ask ourselves whether snakebite is a pressing problem, then yes, the annual snakebite mortality is around 60,000 per year in India. And India, as we can see here, this is the recent global burden of mortality study. So India, as we can see here, is the highest high burden country in the world. So, and it has remained so since 1850s, and recent trends suggest that snakebite mortality has not gone down. So for comparison, now annual snakebite mortality has exceeded HIV mortality, and the focus which we have on HIV, we usually don't have on neglected tropical diseases, especially like snakebite. So if we look at India as such, this study came out last year. It was an estimate of prevalence as well as deaths. Rajasthan state was ranked 6. But within the GBD, they have done an analysis, and now they have made Rajasthan into an even higher burden state, and it ranks 3 in terms of 8 standardized death rates, which means that it is definitely a very serious problem for us in Rajasthan. So the prevalence is high and the mortality numbers are also high. So if we look at some basic classification of medically important snakes, in India, the broad classification is between elapids and viperids. So elapids usually present with neurotoxic manifestations, neurologic manifestations. The elapids include the cobra and the krait. So, and the viperids include all the vipers. So under vipers, we have Russell's viper, we have the saw-scale viper or Echis carinatus, and we also have other Malabar pit vipers, which is now emerging as an important snake, which is causing a lot of envenoming in southwestern India, hypnil, and also some northeastern green pit vipers. So these all come under viperids. The viperids cause hemovascular toxic manifestation, in which patient predominantly presents with bleeding. So if we actually look at the snakes which are responsible for maximum venomous bites in terms of numbers in India, the so-called epithet of Big Four has been coined. So the reason for Big Four is not exactly the relevance, because we are seeing that now regionally, we'll also see in Rajasthan what are the regionally venomous snakes which are coming out to be more important. The most important thing is the current polyvalent ASV, which is being produced by around 22 companies in India. All of them, the polyvalent ASV which is available in India, works against only these 4 snakes. The reason is the venom of only these 4 snakes are collected, then they are injected into horses, and then horse serum is collected, and then the freeze-dried ASV is made. So only these 4, we have antivenom which can address only these 4 snakes, and which is why regionally important snakes such as we will be seeing Echis carinatus oshiriki, which is a regional subspecies, as well as the Sindh krait, do not respond very well to the available Indian polyvalent antivenom. Currently, monovalent antivenoms exist, but they are not commercially available in India. So around 236 snakes are there in India, out of which 19 are venomous and 4 are considered dangerously venomous. So they are the Indian cobra, the common krait, Russell's viper, and saw-scale viper. So apart from this, there is the banded krait, and we have Sindh krait in our area. Also, Indian cobra is considered a species, but we have the North Indian cobra, which is distinct from the monocle cobra in our area. In terms of the polyvalent ASV which is available, as I was saying that the polyvalent ASV is available as a freeze-dried powder. So currently it does not require cold chain to be stored, and it can be stored just as it is. It is to be reconstituted with 10 ml of saline or distilled water and used after reconstitution, freshly after reconstitution. It should not be stored after reconstitution. So the current indications for giving antivenom as well as the dose is mentioned here. So if the patient, for giving antivenom, we do not need to know the species which is causing the envenoming, because we have a single antivenom, we can perform syndromic diagnosis. If we say that it is a neurotoxic snake, neurotoxic envenoming, which we can find by clinical signs such as ptosis, ophthalmoplegia, weakness, or respiratory paralysis, then the initial dose is 10 vials. So it is reconstituted with 10 ml, so 100 ml is the initial dose, and subsequent doses are repeated every hour. So after 1 hour we recheck whether the symptoms are persisting, and if so, the signs of neurotoxic signs are persisting. If so, the dose is repeated. So the total dose for a neurotoxic envenoming, be it cobra or crate, is 20 vials or 200 ml. And in terms of hemovascular toxic, there is some controversy. There are various regimens which have been proposed, but there is no, the initial dose is clearly evidence-based, so 10 vials is needed upfront. The subsequent dosage, WHO recommends that the full dose, that is 10 vials, be given every 6th hourly if we find that the blood is still incoagulable. So either if the patient is bleeding overtly, we find that there are bleeding manifestations, or we perform a simple bedside test which is called the 20-minute whole blood clotting test. So it is nothing like we just take a test tube, place 2 ml of blood in that and keep the test tube for 20 minutes. We don't disturb it for 20 minutes. After 20 minutes, we take the test tube and try to just tilt it to see whether clot has been formed or not. If the clot is formed, then it is negative. If the blood is still running, it is positive. So this test has been found to be quite specific, though sensitivity is little less, which means that if a test is negative, it has to be repeated within the next 1 hour. But if the test is positive, then yes, there is hemotoxicity. The 20-minute WBCT has also been shown to correlate with the hypofibrinogenemia in earlier studies. So this is a bedside test we perform. So if WBCT is positive, then we give 10 vial every 6th hourly till the WBCT normalizes. So there is a upper limit to dose which has been calculated based on how much venom of each snake the antivenom can neutralize. Based on this, the upper limit for Russell's viper is calculated as 30 vials and Echis carinatus is calculated as 20 vials. So overall, there is no indication to exceed beyond 30 vials in any case of snake bite. So this is the maximum ASV which needs to be given. So if the ASV is not working in 30 vials, it means that it is not working, and that is not an indication to give further doses of ASV. So the second regimen is giving 6 vials or 3 vials every 6th hourly. This has been recommended in the National Snakebite Protocol in 2016, but currently we follow the WHO protocol in our institute. So coming on to the regionally relevant snakes for us in Rajasthan, the far left, which is this is the Echis carinatus shoshirecki, or the Shoshirek saw-scale viper. So the distribution of this snake is throughout the Thar desert area. So patients whom we get from Jaisalmer, Badmer, and also beyond it is also distributed up to Pakistan and even in the Middle East. But this recently, also in today's case, we will be focusing mainly on Echis carinatus shoshirecki. This snake, at least in our experience, this does not respond to antivenom. The second photo here is that of the Indian cobra. This is the North Indian cobra. It looks little different from the monocle cobra which we usually see in pictures. So this is a commonly found cobra in our area. And this is the Sindh crate, which also is localized in the desert area. So because these reptiles have evolved to survive in the desert area, the habitat which is very different from the usual snake habitats in the rest of India, the venom which they produce is also different depending upon what they consume as prey, and because of this the venom composition is significantly different from the rest of India, which is why we are facing the problem where the polyvalent antivenom, where the venom is collected from somewhere else, is not working for us. So next we will move on to the case presentation as such. So the patient who came to us was a 50-year-old. He had come from Badmer. He was a farmer, and he had a bite over the right foot, you can see here, and this was the initial day 1 presentation. With bite over the right foot, he had local swelling and he had also some local oozing as well as pain. So with this, he had reached the nearby hospital within 6 hours, and within 6 hours he had reached the first health facility. And in the primary healthcare, he had received 10 vials followed by another 10 vials, so he had received 20 vials before he came to us. So on day 2, he came to AIIMS. Still WBCT was prolonged. That was the reason for referring him, because he was bleeding from oral cavity, he had frank hematuria, and also patient was having local oozing. So we have given a further 10 vials of ASV at 24 hours because the maximum dose is 30, so patient received 30 vials of ASV. At presentation, patient was also hemodynamically unstable with a blood pressure of 86/60 and a pulse rate of 68 per minute. So because patient was actively bleeding and he was hemodynamically unstable, the patient was shifted to adult ICU. So this was a photograph of the snake brought. This is a photograph of the snake brought by the patient's relatives, and this was identified morphologically as Aedes keratososchoriki. However, the photograph is not very clear. So further course in the hospital, if we see, so patient came to us on day 2. This is the yellow arrow which you are seeing. So on that day, we have transferred him to ICU. So patient's ICU stay began from that day onwards, and he had presented with hypotension. So luckily, the hypotension was corrected in the first 24 hours with only fluid resuscitation. He did not require any inotropic support. However, he did receive transfusion, which I'll be now mentioning. So this is just a table of investigations which were done for the patient on day 1. So suppose we see here, here I have put in the renal functions, that is urea, creatinine, hemoglobin, and the prothrombin time. However, we have also done APTT, serum fibrinogen, and other values, also WBCT. But for clarity, we are just focusing on these 3. So on day 1, the patient's hemoglobin outside was 14.5, while the INR was 1.52. And when he presented to us, it was already 10.4. So he had had a significant HB drop, and INR was 1.4, while urea creatinine at presentation on day 2 was elevated as 126 and 4.9. So here, patient also had breathing difficulty, so it was suspected that patient has fluid overload and pulmonary edema, and also he was having oliguria, decreased urine output. Considering these things, an IJV dialysis catheter was placed by the night because he was oliguric, and on day 3, patient underwent the first session of hemodialysis. The brown triangles which you see are the hemodialysis session which the patient has received. So following this, so patient, if we see the hemoglobin trend, we find that patient had a significant dropping trend of hemoglobin. So it was 8.6 followed by 6.3, and on day 7 it had become 5.3 and so on. So on day 10 it was 4.5. So during this period, there was no overt bleed access, there was no upper GI bleed, or hematuria was still persistent. So during this period, patient received transfusion support. Also, you can see here that the coagulation parameters were deranged. The INR was 1.4 followed by 2.48, and then there were 2 readings where the INR was not recordable with our machine. And here, post transfusion, probably he got it corrected to 1.25, and again it started increasing. So during this period, patient received transfusion support in the form of PRBC, FFP, and cryoprecipitate. So because patient had breathlessness, though he did not require any significant oxygen support, it had also been suspected that patient might have a diffuse alveolar hemorrhage, because there is a significant HP drop here. There was no clear-cut bleeding which was being seen. So patient was suspected to have a diffuse alveolar hemorrhage. So for that, patient had undergone a CT thorax, which was done around day 8. And that showed pleural effusion with bilateral mine ground glassing. So the possibility of diffuse alveolar hemorrhage was low, and the possibility of pulmonary edema was kept higher. So the bedside echocardiography was done during this time, and that was also normal for the patient. So further during the course, because there was a significant HB drop, there was thrombocytopenia. So the initial platelet count which the patient presented with was around 32,000, and the nadir platelet count was around 24,000 on day 4. And there was and also there was a suspicion of thrombotic microangiopathy. Patient was planned for plasma exchange. So one session of plasma exchange has been given on day 4, another on day 10. But once the suspicion of diffuse alveolar hemorrhage and thrombotic microangiopathy have been cancelled, then the further sessions of plasma exchange were not continued. So following this, on day 18, patient's platelet count normalized. It came to around 1 lakh. So before that, he had slowly started platelet counts had started increasing. On day 23, the VICC is the venom-induced consumption coagulopathy. The coagulopathy abnormality is completely resolved by almost day 23. So you can see here the INR reached around 1.86 to 1.66, and then it went below 1.5, and by day 33 it was 1.24. And but patient continued to have acute kidney injury, for which he was receiving multiple sessions of hemodialysis because he was also oliguric. And after multiple sessions of hemodialysis, the renal parameters slowly improved, and on day 29 he was transferred to the medical ward. And after which, on day 33, he was discharged home with resolving trend of, you can see here that the creatinine discharge was 4.8. So with a resolving trend of AKI and good urine output, as well as normalized coagulation parameters and hemoglobin around 8.3. So hemoglobin had also stabilized here. So patient came back again within 8 days to our OPD. Here his complaints were okay. So here his complaints were, he complained that he had weakness, he was unable to walk with bilateral lower limbs. So at this point when we examined, we found that patient's bilateral lower limb, there was weakness, power was around MRC grade 4/5, and there was also sensory loss, which was for pain, temperature and touch, and that was left side more than the right side. So patient was walking with support over here, and he also complained of bilateral lower limb pain. So it was a painful weakness. So some nerve compression was suspected and patient was readmitted. So in the second admission, patient underwent ultrasound in the ultrasound of the pelvic area, and he was found to have a pelvic hematoma, which was significant. And the cause for this lumbar plexopathy, we found that might possibly be this pelvic hematoma, which was compressing because psoas muscle also had a hematoma, and that was the reason for lumbar plexopathy. So the lumbar plexopathy were also confirmed on nerve conduction studies, which showed that both motor and sensory involvement is there. And then during this time, patient also underwent drainage of the pelvic hematoma, which was CT guided, and post that patient started improving, at least the pain was relieved and the power was slowly improving over the next few weeks. So overall, if we see, patient had venom-induced consumption coagulopathy in the initial phase, up from day 1 to day 23, which presented as hematuria, local bleed and a significant HB drop. Then patient had acute kidney injury in the initial phase. It had pulmonary edema, decreased urine output and acidosis as complications, requiring multiple hemodialysis. And in between he developed a lobar pneumonia, for which he had to receive antibiotics. So these were all the manifestations, clinical manifestations, which he developed during hospital stay. So again, yeah, this I've already mentioned, that he underwent a nerve conduction study as well as ultrasound and CT during his second admission. And on day 50, he was discharged, that he was able to walk with support. So this was the total duration of course. So we see here that the clinical course was complicated by multiple complications in this patient, starting with consumption coagulopathy, then acute kidney injury, hospital-acquired pneumonia, which required antibiotics, followed by a delayed bleeding manifestation, that is collection and a pelvic hematoma, which further caused neurological manifestations such as weakness and pain. So this I've mentioned already, that on day 42 patient presented with neurological manifestations, and nerve conduction study confirmed the presence of lumbar plexopathy. So if you look at the imaging, this was the ultrasound image which was done when the patient had come initially, and it shows a huge collection which is around the size of 5 into 5 centimeters. And this is the aspirated, this was actually frank blood we had aspirated, and that too it was incoagulable, though when at admission patient did not show any coagulation abnormalities. And this is the post aspiration CT, so that showed decrease in collection afterwards. So here we also see the serial chest x-rays which were done, and which shows that patient had developed lobar pneumonia somewhere around day 8, day 15, and which later resolved with antibiotics. So if we look at the clinical outcomes, patient had VICC, which led to pelvic hematoma, later lumbar plexopathy, which pain and paralysis, which resolved. Patient had acute kidney injury, which led to pulmonary edema, oliguria, which required hemodialysis. And currently, in the last follow-up, that was around 3 months from his discharge, creatinine was still 1.68, which, considering his age, makes him as stage 2 CKD. So he has gone for chronic kidney disease. And he also had pneumonia, which is resolved. So if we look at drugs, procedures and other outcomes as such, the amount of ASV used was 30 vials, which is the maximum dose. He had 8 sessions of hemodialysis, 2 sessions of plasma exchange. He had a central line for hemodialysis catheter. He had an arterial line. He required around totally 109 transfusions, 2 platelets, multiple FFPs, cryoprecipitates, and around 8 to 10 PRBCs. He has undergone 17 X-rays in hospital. 3 times he has undergone CT imaging, including both the admissions. Once he underwent a guided aspiration, and he received IV antibiotics for around 20 days. His ICU stay was 30 days, and total hospital stay, including both admission, was 50 days. And his total loss of days lost from work is around 90 days. So this is the summary of morbidities which the patient underwent. So this is the end of the case as such. I would like to just show our institute data for snakebite in the last 20 months, which is 2021 and 2022. So if you see, we had totally 62 bites, out of which viper bites have been predominant both last year as well as this year, and cobra and crate bites. This year neurotoxic bites have slightly increased, even though we are still only in September, and some dry bites are also there. So last year the mortality was 2 out of this 29, which is around 10%, and this year already we have 2 mortalities, both of which are, all these 4 mortalities are hemovascular toxic or viper bite patients. So the median hospital, we have not actually calculated the median, it's just an average, 13.3 days last year and 4.46 days this year. But having said that, we are just starting with snakebite admission season. I think during monsoon we'll be getting more patients. So ICU admissions were 9 last year and 13 this year. Central line insertions were 12 last year and 3 so far this year. And plasma exchange we have done for 4 patients last year and no patients this year. And hemodialysis 4 last year and 1 this year. And invasive ventilation was needed for 4 last year and 6 this year. And many of these invasive ventilations this year have been neurotoxic bites who have successfully been weaned off ventilation and discharged. So ASV reaction, we have had totally 5 ASV reactions in the last 2 years, and all of them have been non-life threatening, and ASV has been rechallenged for all the patients. So this is the summary of the data which we have had for last 2 years for adults. So if we come on to the discussion, the first glaring problem which we find is this VICC, that is the venom-induced consumption coagulopathy, and the persistence of venom-induced consumption coagulopathy. So the coagulopathy is supposed to resolve within 24 hours if ASV is given at the right time, and without ASV it is known to go on till 7 days. So this is the usual previously described literature, but in our case we have found that patient, even in week 2, patient is still having coagulopathy, like during day 10 it was 1.58, and finally it has resolved only around day 23. So here the reason for saying that it is resolved in day 23 is serum fibrinogen values came to normal only in day 23. So he had asymptomatic serum, he had asymptomatic afibrinogenemia or hypofibrinogenemia, so to say, hypofibrinogenemia even after the INR normalized. And this is a trend we have been finding in most of our viper bite patients, that this dysfibrinogenemia or hypofibrinogenemia is persisting. In fact, for one patient has persisted almost 2 months of follow-up, still the fibrinogen levels are not normal. So this is something which is very unique and which is surprising in our part of the country. So this patient we had seen in September 2019, this was the first patient, and who had 7 days of prolonged coagulation parameters as well as fibrinogen, and patient, but he was thankfully asymptomatic, and patient was discharged well. So this was, and on day 10 the parameters had normalized. So this was in 2019. And this has been previously reported. In 2007, the rediscovery of Aequus tochereki saw-scale viper has been reported from Bikaner. So it was previously, and even in this series, multiple patients had prolonged bleeding, but most of them were controlled in 7 to 10 days. And in July 2021, again we had experienced a very rare and let us say difficult to manage manifestation of diffuse alveolar hemorrhage, and this started after the VICC resolved. So once the VICC had resolved, in week 3 this patient had a massive diffuse alveolar hemorrhage, and this patient was managed with plasma exchange as well as steroids, and the patient survived. So this was also in July 2021. So if you look at delayed hematoma and internal bleeding, there are reports, especially from Ekes Oshiriki. So there have been reports of broad ligament hematoma, and there have been reports of hemoperitoneum. In fact, some years ago, this delayed psoas hematoma, this was on day 6 and day 7, has been reported from Jodhpur. So if you look at what is the mechanism of venom-induced consumption coagulopathy and why does it persist? Why is our patients, why are they not recovering within time? We need to look at little bit at the composition of the snake venom. So the snake venom is a cocktail of proteins and enzymes, and there are multiple enzyme and non-enzyme components. So many of these enzyme components are known to act on the coagulation pathway. So the VICC or venom-induced consumption coagulopathy has been defined as distinct from the usual DIC which we see, because the inhibition to the clotting pathway is at specific points. Like for Russell's viper, it is at factor 5, factor 10, or for Ekes carinatus, it is specifically at the level of prothrombin. While in DIC, there is widespread dysregulation of the coagulation pathway. In VICC, usually there is no obvious fibrin deposit, though subset of patients have thrombotic microangiopathy. VICC usually presents with bleeding, whereas DIC can present with both end organ manifestation as well as bleeding. So usually these end organ manifestations are not described in VICC. This is the classical description. However, we are seeing multiple patients who are presenting with AKI and who have gone on to CKD, and the mechanism for which is not clear. So if we see the venom toxins in viper venom which are linked to VICC, we find that there are 4 types. One is the prothrombin activators which are present in Ekes, factor 10 and factor 5 activators which are present in Russell's viper, thrombin-like enzymes and hemorrhagens. Hemorrhagens are also present in Ekes, but thrombin-like enzymes are usually present in Australian snakes, that is Elapid's snakes. So very briefly, I just wanted to show the same thing, that factor 5 and factor 10 activators are present in Russell's viper. Prothrombin activators are present in saw-scaled viper. They are the E-carin, and Australian elapids are also prothrombin activators. Also, they have procoagulant factors. So there is a slight difference by which the prothrombin is activated to thrombin in Ekes and in Australian elapids. So the Australian elapid use the same factor 10A, 5A complex to activate prothrombin to thrombin, which is the normal pathway in human beings. But the Ekes venom E-carin, what it does is it converts prothrombin to mesothrombin, and this mesothrombin is also an active component, and mesothrombin then further converts the prothrombin to thrombin also, and this is non-calcium dependent. So this is a slightly different mechanism. And finally, the fibrinogen is converted to fibrin, and then there is fibrinolysis and then fibrin degradation products form. So this is the broad mechanism as we understand it today for VICC. So if we see what is the problem with our regional Ekes Oshiriki, there are multiple preclinical studies which show that the venom composition of Ekes Oshiriki is different from that of the Ekes carinatus, which has been taken from either Maharashtra or Goa or Tamil Nadu. So two serine proteases, so snake venom serine protease and cysteine-rich serine protease. So these are the components which are higher in our area, the venom composition in Ekes Oshiriki compared to Ekes carinatus. The clinical implication of this is still unclear. We don't know what exactly this means for us clinically, except that we know that it does not respond to ASV. So if we come and answer the next question, does FFP cryoprecipitate help because our patient has received multiple transfusions, or does it just add fuel to the fire? So if you look at the current evidence, the FFP is known to help in elapid envenoming, that is in the Australian elapids which cause bleeding. But RCT was done for Russell's viper which showed that FFP did not hasten recovery from coagulopathy and it did not improve mortality. Again, this is the only randomized clinical trial which we have for vipers so far. So there was another study which was conducted recently in the southwestern coast, Mangalore, which includes 62 patients, and many of these patients were the hypnale, not our Ekes. So we actually don't know whether FFP cryoprecipitate works in Ekes envenoming, but it has to be used cautiously. So this is a pit viper. Again, they gave both cryo as well as FFP, and this is a Chinese study. But this also showed that there is no improvement in mortality or time to recovery with use of FFP or cryoprecipitate. So this is the current evidence. And in terms of role of therapeutic apheresis in snakebite, Initially there have been case reports and case series where therapeutic apheresis has been performed and patients have improved, especially in the background of thrombotic microangiopathy. So apart from that, now there has been a systematic review which has collected multiple 5 or 6 RCTs as well as some observational studies, and it shows that therapeutic apheresis is not recommended. Based on this, a current recommendation has also been made that it does not appear to work in thrombotic microangiopathy in snakebite. Having said that, none of these studies have included saw-scale viper, even Echis carinatus carinatus, so obviously there is no study for Echis schwarzschildii. So if you look at the logic of using Plex, so first question we have to ask is, are we trying to remove the venom? So because the venom binds within 24 to 48 hours and Plex can remove usually the non-bound venom, the answer is no. So second is, Plex can also remove antivenom if we are giving it early enough. That is one thing which we have to remember. And what about diffuse alveolar hemorrhage? If there is an antibody mediated mechanism, then we don't know the answer to this, whether Plex will actually work in Echis carinatus schwarzschildii. Could the AKI have been prevented? Possibly yes, if we had an effective ASV. So clearly this is ASV failure, because VICC we know may not respond to ASV, but there is clear evidence that if ASV is administered early enough, then AKI will be prevented. So we have an ineffective ASV, and if we look at the mechanism of AKI, it might be direct venom effect versus thrombotic microangiopathy. In this patient, we don't have an evidence. So again here for Plex, if we see Plex did not reduce the need for dialysis or outcomes in thrombotic microangiopathy with AKI. So simply one slide to show what the future holds. We are now having some small molecules and inhibitors which are toxin inhibitors directly. The Varsiplatib, this drug has come into clinical trials, while Marimestat is still in early phase of clinical trials. The need of the hour appears to be regional antivenom. That is, we need a venom collection area or venom collection farm, as we may say, somewhere in Rajasthan, so that the local snakes can contribute to the venom and the polyvalent ASV can be just produced from the venom of the local snakes. Because currently all of the antivenom in India is sourced from a single source, that is from near, that is from Tamil Nadu, that is near Chengalpet in Tamil Nadu, so that is where from all the venom is sourced to all the companies. So this is probably the important thing which we need to change. And there are 2 regional antivenom centers which are already approved, one in Gujarat and one in Bengal, and Rajasthan. I think we are also advocating highly for a regional antivenom production at Rajasthan. So what the future holds, camelid antibodies have been shown to be effective, and currently Indian Institute of Science along with Camel Research Institute in Bikaner is exploring this as a antivenom for Echis as well as Snakebite, and this is still in preclinical stage. They have informally reached out to us that when this comes to clinical trial, AIIMS Jodhpur will be probably one of the centers involved in that. So I'm coming to the final slide, that is the morbidity audit. We have looked at all the drugs and procedures used. Was it an avoidable morbidity? So ASV used is 30 vials. Was it avoidable? Definitely no, but maybe we could have limited it to 20 vials. This is something we should consider in future. Hemodialysis 8 sessions, there was no way we could have avoided this. So the plasma exchange 2 sessions, yes, probably we could have avoided this, considering the current evidence that it does not produce any clinical benefits. We may not use it in future. This year so far we have not used for any patient. IJV line, no, we could not have avoided. Arterial line, patient had one, possibly could have been avoided. The current recommendation for current guidelines, WHO guidelines recommend strongly against placing arterial lines in viper envenoming. So transfusions, patient had 109 transfusions. Could it have been avoided? Possibly yes. Most of the transfusions were because were linked to the plasma exchange, so patient had received a lot of FFP in that. Chest x-rays, patient had 17. I think yes, this could have been avoidable. Maybe we could have reduced this a little bit. This I think we'll have to look into this one. CT imaging, no, patient required the CT imaging. Guided aspiration, no. IV antibiotic 20 days, possibly we could have. There is a scope for our antimicrobial stewardship here. This is the final analysis, which is the morbidity analysis in terms of fishbone and possible solutions. So usually the fishbone analysis comes in 6 parts, that is whether any place factors, policy factors, provider factors, patient factors, procedure factors and others which have contributed to the morbidity. So place factors, we see that we live in a high burden area where the regional antivenom is ineffective, and we don't have effective antivenom, and there is a clear problem for access to care because patient needs to reach Jodhpur, which is around 24 hours. So policy-wise, yes, ASV protocols are there, which are mostly focused on the big four. We need to have regional ASV protocols, which will work, maybe limiting ASV, transfusion as well as plasma exchange protocol. Currently, no evidence exists. Maybe this is an area which we have to focus on in future. Procedure-wise, we have already seen in the previous slide multiple procedures, whether they were avoidable or not. Others, early screening for abdominal bleed, there is a possibility that before discharge, if we had tried to screen the patient for pelvic hematoma, we might have found it. But patient came back with a complaint of being not able to walk. The patient factors, yes, patient presented by 6 hours, which is also little late as far as snakebite goes. Age is a risk factor for CKD, he has developed CKD, and patient education is very important to know that this patient did not go to any traditional healer, this patient did not have any local procedures done, which was a plus for us, but in general patients go to traditional healers and come late. Provider factor, yes, providers need to be aware of, we have to be aware of the current evidence, and also there is provider preference in terms of giving transfusion and plex, also the chest x-rays. I think those we have to take into consideration. So with that, I'd like to close my presentation. Thank you. I'm happy to take any questions and discussion.
Lucid presentation.
Thank you, sir.
Just questions. How many cases identify the snake was the reason of problem?
Sir, here the...
Just let me finish. Second thing, is it possible to diagnose by any other investigation, physiological or something, which snake is the reason? Because
yes, sir.
most of the time, don't know which snake is the reason. Third thing, is it possible to anywhere in the world
yes, sir.
get some vaccine type of thing?
Yes, sir. I'll tell you, sir. So how many patients bring the snake? So there is a trend here. Usually they don't bring the cobras. If there's a cobra bite, they don't kill the cobra and bring the cobra. So most of the viper bite patients do bring it. They
know that which snake was the reason. They know in how many cases?
Sir, they actually kill the snake and bring the snake and they show us. So for I think 80% of the patients do that. Crate, usually the crate is not at all found. So the crate bite is asymptomatic. Usually crate bites and there is no local envenoming. So crates they don't bring, but most of the viper bite patients bring it. Having said that, we don't need to know which is the snake because current situation is we have only a polyvalent ASV. All we can do is administer the same ASV. It's only the dose and the duration which we need to know. So for the public as such, it is strongly discouraged that they should kill the snake and bring it. One, it is not ecologically, environmentally friendly. Second, there is a risk for a second envenoming when someone goes to have a new human-snake conflict. Sir, as far as species diagnosis goes, there are point-of-care assays as well, and there are antibodies available for finding out which is the envenoming. So in Australia, they routinely use it. They have point-of-care assays, which is like a swab from the local site, and they put it like a ELISA. There is a lateral assay test, and they can tell which is because they have monovalent antivenom. And in Sri Lanka, they had developed it for Russell's viper, and they had used it in clinical trials, but it is not commercially available at present for clinical use. In India, they have developed in the Research Institute in Haryana, I think it is IISCR, they have developed one for cobra last year. They are using Aptamus. The problem with this is that the venom of a non-venomous and the venomous snake, it is so mimicking very closely. So many times there are false positives. In Australia, they found that the false positive rates are up to 40%. So now the swab test has been given up. Initially, it was a very huge success, but now that has been given up. So point-of-care assays are still being researched in now currently CCMB as well as Indian Institute of Science both are working on point-of-care assays which can be stable and which can be more specific. Currently commercially it is not available, but research is underway. Also said there is like one of the patients we had sent, one of the patients in the series, not this patient, we had sent the blood and urine to Indian Institute of Science on day 3 to see whether venom is actually detected from that or not. To our surprise, no venom was detected, even though patient was bleeding and the patient had an IC bleed and the patient died ultimately. On day 3 and day 4, patient venom components were neither detected in the blood nor in the urine, which means that the venom is not actively circulating. It has set up the coagulation pathway, and the coagulation pathway is continuing by itself, but the venom components are not there. Maybe they are bound already somewhere in the tissue, but active venom components were not found in circulation. So that's again poses a question of whether we need to do delayed plasma exchange or plex or not. So this is one of the things. Vaccines are now, only during COVID this topic has come up, that whether we can vaccinate against snakebite. Currently there are no, to my knowledge, there are no clinical or preclinical studies anywhere in the world.
Dr. Maya,
Yes.
your presentation has touched many points
Yes, sir.
as an educational presentation, and one thing is that you have touched about the morbidity. That is what went right in managing this patient and what we could have avoided. So this is also very good idea, that is our residents knows about how to manage. Also it has touched upon the awareness, that is awareness is required, and thirdly it has like we can have a center for these studies. This is very highly required in Rajasthan. And your fishbone analysis put up another area in which our institute is working on is quality improvement.
Yes, sir.
And because of based on these data, we can prepare like Pareto chart also. So 80% of and 20% ratio. So we can target what are those 80%, 20% for which we can devise some methods. And I think you have highlighted very importantly that hematoma, pelvic hematoma is one of the condition which can prevent the morbidity and the mortality.
Yes.
Another is that you have shown huge data about our institute experience.
Yes, sir.
Do we have the data from the forensic medicine, because they are maybe having some deaths which have been brought for the autopsy? So is that has been included or?
No, sir. Currently, this is only a clinical data. We have, I think, sir, we must approach them to include the broad dead patients as such. I think that is it's a very, I will take that suggestion, sir.
I think this has given a very high input for the biochemical, microbiological, as well as hematological dysfunctions, which can be learned by the residents.
Yes,
and I
sir.
think holistic management of the patient is one of the most important key. Excellent presentation.
Thank you, sir. Thank you very much, sir.
Snakes are really scary. So would you like to attribute the intravascular hemolysis leading to AKI and the fall in hemoglobin continuously?
Sir, as such, there was no myoglobinuria. There was hematuria. So if you want to say whether intravascular hemolysis and there was myoglobinuria and
No, not
that,
myoglobin, hemolysis only.
that is hemoglobinuria or myoglobinuria, that was not there, sir. That was screened for on day 2, day 3. That's also something which we routinely screen. Yes, there was active intravascular hemolysis. LDH was increasing. That is venom-induced consumption coagulopathy. There was hemolysis. There was thrombocytopenia, but that does not seem to be the direct cause for acute kidney injury. It could have been a thrombotic microangiopathy. We did not have sufficient evidence for thrombotic microangiopathy except after the first peripheral smear. So that's why plasma exchange also was not continued. So that is a possibility, and direct venom action is also possible.
Right.
Thank you, sir.
My excellent presentation.
Thank you, sir.
The question is this: ASV is available at peripheral health center and community health center.
Yes, sir.
But what we have seen that doctors working at primary health center and community health center are referring the patient. They are scared of anaphylactic reaction. So how we can train, how we can build the confidence of peripheral doctors so that means they are unnecessarily sometimes referring the patient and delaying providing ASV bound to the
Yes, sir.
issue
It
and
is
protocol.
I think it's a very relevant, and it's a common problem which we are also facing. Luckily, in this patient, he had received adequate amount of ASV before coming, but in general, patients receive either no ASV or inadequate ASV, and they are referred. So I think, sir, as you have rightly pointed out in the question, we probably need to conduct some kind of training. We can invite, we had previously, sir had also said, we can call the primary healthcare doctors, and maybe we can conduct training session and allay their apprehensions according to about ASV reactions and how they can be managed. So probably it is strengthening the capacity at primary care level in terms of both provider as well as currently the availability of ASV, which is now good, which will prevent this kind of morbidity while patient getting referred to tertiary care center.
Actually, there is no treatment currently for this snake. One pediatric patient also with amputation and CKD, the same patient. So only the public awareness and the preventive option available as of now.
Yes, sir.
For that, anything's ongoing or we can plan to public awareness to prevent the snake bite.
Yes,
the
sir.
risk area, timing and the environment where they can take highest risk of bite. That is the only option. For that, we can as a proactively act with help of public health team.
Yes, sir. Currently, I think this is a very important point. We don't have anything in our arsenal to offer to these patients. None of the interventions which we are offering to these patients seem to have any evidence that they work. So I think prevention part has to be emphasized even for patients for secondary prevention and as well as other outreach campaigns.
Are these patients medico-legal? Do they get
Yes, sir. They are all under they are all medico-legal.
Usually the patients are
Yes, sir.
getting
They are medico-legal. All patients are made under medico-legal case sheets when they come to the emergency. So the police is notified for each snake bite.
Post-mortem was done in the 4 days.
Sorry, sir.
Post-mortem.
Sir, patient has survived. So, but
There were two.
there were 2 deaths.
2 deaths.
Currently, it is not a requirement. I mean, to my knowledge, we have not performed post-mortem on these 2 patients.
And was there any suspected case of snake bite? Because there are, but in Bihar, there are many patients who have suspected snake bites. Threats usually, Bihar
Yes,
and
sir.
UP is very common, say, they are painless bites. Patients present differently, and then there is a diagnosis.
Sir,
suspicion of diagnosis that-
in
was
this
there any
also we had almost all the crate bites had presented like that. So we had one brother and sister. The younger sister was admitted under pediatrics and elder brother was admitted with us. So brother had come the previous day and he was just brought unconscious. Nobody knew what it was. So on basis of just suspicion, ASV was given to him and he was transferred to ICU. In fact, he had a cardiac arrest and he post CPR, he survived, and after ASV he sat up. Next day morning, sister came with similar symptoms, but we could pick it up early. Later they found the snake at home. So many patients come with suspected snake bite, and especially crate bite, it's well described, like you said, early morning neuroparalytic syndrome. So that we do see, sir, it's quite common here. But as such, patient brought dead with suspected snake bite in these 2 years, there is none to our knowledge. But as sir has suggested, I think we'll corroborate with forensic medicine once.
Crates sleep on the wall. They lie on the roof most of the times. The roof is not. They fall, bite, and many patients. And when we were,
Yes, sir.
that was very common.
Sir.
Thank you, Dr. Maya.
Thank you, sir.
Indeed, an excellent presentation. And I recall the case which you are discussing right now, that alcoholic patient brought unconscious to the emergency, and because of chronic alcoholism, his liver functions were pretty deranged, and there was reasons to suspect hemotoxic envenomation, but ruling out assault, poisoning and all other things, an empirical ASV was given, and he has all signs of brain death. He was received E1 VTM1.
Yes, sir.
He was intubated, and he was empirically given ASV, and he walked home.
He walked out of the ICU.
And just evidence in support of envenomation was that her sister.
Next day, sister came with the exactly same symptoms, and she received early ASV actually. And parents also, for the boy, I think they had gone to a traditional healer in 2-3 places, and then they came back. But for the sister, they brought immediately to hospital.
And usually the bites patients encounter sometimes when they are sleeping, so nobody recalls what happened. They finds the patient unconscious. Sometimes there are no fang marks also there. So it's sometimes pretty challenging, and patient does not usually gives an history of bite.
So high degree of suspicion for especially crate bite is clinical suspicion, and maybe empirical ASV at that point is highly indicated. So this year also most of the crate bites have come like that only.
Thank you.
Thank you, sir.
Dr. Maya,
Sir.
you have said about this traditional healers. So we have this program at tribal area Abu Road. So we
Yes,
have
sir.
collected data from 1,000 tribal healers, and I think we could analyze that also. For For
Yes,
the
sir.
capacity building, the tribal healers may be very important, play a very important role in managing these bites.
Yes, sir.
I think this capacity building can also be initiated for them also. Yeah, they can also be have trained about what is the management option and when to refer, not to delay.
Yes, sir, I
The
think we
training
can,
of the primary health center doctors will also.
tribal areas.
Thank you, Dr. Maya. It's
Thank you, sir.
wonderful presentations. And your interest in the snake bite since your MD days is coming forth here. And really, we are learning a lot. And she is collaborated with the UK, Bangalore. She has already met the CCF, that is Conservative Forest here. And we are doing a project to analyze this venom and their components from this part. And this may future, as somebody was suggested, that can lead to the early diagnosis or serum diagnosis and even the treatment purpose. But we have to somewhere, it has to come from the political awareness also. So our institute can write to the state government that look, this problem we are facing, and they can pressurize to establish a venom center at Bikaner or this place, and or to include this venom also into the polyvalent. So somewhere, sir, from this institute we can write to the tribal ministry as well as the state government and highlighting the data and these things. So this will help, may prevent many morbidity and deaths. We have the ASV, as you told, that if the ASV was effective,
Yes, sir, none of this would have occurred actually.
nothing was. So first thing what I think is required is the effective
Regional ASV.
ASV. And secondly, we can write to the state government to make aware, as problem was that we can conduct a seminar or conference for one day for the primary care physicians about making them aware about the snake bite intricacies and what is to be done and what not to be done. So I remember in my MD days, I've given even the 100 vials of the ASV because the patient is not improving, you are back to the wall. It was 40 years back. We are giving 10, we are giving till the patient death, we keep on giving. So now the things are coming up, things are improving. Definitely with your effort and many persons working on this, this mortality and morbidity we can reduce.
Thank you, sir.
Else is the case is medico-legal will help farmer compensation. They are not medico-legal enrolled. That is a financial part of health.
Sir, morbidity, I think currently there is no compensation in Rajasthan. Mortality is there, definitely.
FAP may be counterproductive, not evidence.
Yes, sir.
Because as you told that post-mortem is not done because death causes, the police say it is not required. When the cause is obvious, if the foul play they suspect, they can order. Because cause of death is obvious. Foul play is something else. That's why post-mortem is not done.
Sir, in several states it's mandatory, like Tamil Nadu, Pondicherry, and I think even Bengal, it is mandatory for snakebite deaths to undergo. I think currently we are not sure of this one. Thank you, sir.